Hello, everyone, and welcome to our WVS webinar on CPR, which is based on the 2024 RECOVER guidelines. It's going to be presented by our wonderful vet, Dr. Sumant. So without further ado, I'll hand over to him, and I hope you enjoy.
Thank you, Dr. Beth, for the introduction. Good evening, everybody. I'm Dr. Sumant. Welcome to WVS webinar on 2024 RECOVER guidelines for cardiopulmonary resuscitation in dogs and cats. So RECOVER is an acronym. It stands for the Reassessment Campaign on Veterinary Resuscitation. RECOVER initiative was spearheaded by a team of emergency and critical care specialists in 2010. They came up with the first evidence-based veterinary CPR guidelines, which was published in 2012. They have updated their treatment recommendations, and the second edition came out in 2024. So this webinar is all about 2024 guidelines. So in this webinar, we'll be talking about cardiopulmonary arrest, how to recognize an animal in cardiopulmonary arrest. We'll be talking about the different components of CPR, that is basic life support, advanced life support, post-cardiac arrest care or post-resuscitation care. We'll also talk about preparedness, communication, and team dynamics. So what is cardiopulmonary arrest or CPA? In simple words, it is when the animal's heart stops beating and the animal stops breathing. So most dogs and cats in cardiopulmonary arrest suffer from primary respiratory arrest, meaning that they'll stop breathing first, and due to lack of oxygenation, the heart stops beating. It is different in people, where primary cardiac arrest is more common, where the heart stops pumping, and due to lack of blood flow to the brain, the patient stops breathing. Let's talk about some of the signs of cardiopulmonary arrest in dogs and cats. The collapsed animal will be unresponsive. There will be apnea, no breathing, lack of pulse or heartbeat, cyanotic tongue and mucous membrane. Pupils will be fixed and dilated. So within the first 4 minutes of cardiopulmonary arrest, ischemic damage begins to occur, and within 10 minutes, the damage may become irreversible. Therefore, it is very important to immediately assess for cardiopulmonary arrest and start CPR as soon as possible. So when we find an unresponsive animal, it is our top priority to determine if this animal is in cardiopulmonary arrest so that we can start CPR as soon as possible. If find an animal unresponsive, immediately call for help and then shake or stimulate the patient and look for a response. If the animal responds, it is not in cardiopulmonary arrest. If the animal doesn't respond, assess breathing, because presence or absence of breathing is the most sensitive tool to diagnose cardiopulmonary arrest. Sometimes the patient may be showing agonal breaths. Do not confuse this with spontaneous breathing, because agonal breaths are always associated with patient being unconscious and pupils will be dilated and fixed. So if the patient is unresponsive and if the patient is not breathing, then we should immediately start CPR without any delay. So you need to open the mouth of the animal, pull the tongue out, clear the airway, and immediately start CPR. So what is CPR? Cardiopulmonary resuscitation. It is the only practical method shown to achieve return of spontaneous circulation in dogs and cats that experience cardiopulmonary arrest. So CPR potentially reverses cardiopulmonary arrest and preserves vital organ function. It is important to note that survival rates in dogs undergoing CPR is 5 to 7%, and that of cats is 1 to 19%. So if cardiopulmonary arrest is because of a peri-anesthetic drug reaction, and if you initiate CPR, then the survival rates are greater than 50%. If the cardiopulmonary arrest is because of irreversible progressive disease like end-stage CKD, terminal malignancy, in those cases, the prognosis will be poor. So let's talk about different components of CPR. The three components of CPR are basic life support, advanced life support, and post-cardiac arrest care. We'll talk about basic life support first. Basic life support is the first thing you do when you recognize an animal in cardiopulmonary arrest. It is a set of techniques targeted at replacing critical functions of cardiovascular and respiratory systems in patient in cardiopulmonary arrest to maintain oxygen delivery to vital organs. So, basic life support includes chest compressions and ventilation. The goal of chest compression is to replace the functions of ventricles of the heart to generate blood flow. And the goal of intermittent positive pressure ventilation is to provide both ventilation and oxygenation. So if an animal is collapsed in a field condition and if there is only one rescuer is available, then you have to perform 30 chest compressions and a brief pause of 3 to 5 seconds. In that brief pause, you need to deliver 2 breaths and again get back to 30 compressions and 2 breaths. This is called as compression ventilation ratio. 30 compressions immediately followed by 2 breaths. So this has to be done for a period of 2 minutes. But if the animal is collapsed in a clinical setting where there are multiple rescuers, one rescuer can immediately begin the chest compression, that is 100 to 120 compressions per minute for 2 minutes uninterrupted. And the second person can intubate the patient and perform intermittent positive pressure ventilation, one breath every 6 seconds for 2 minutes. So we'll talk about chest compression in detail first. So, and then we'll talk about ventilation. When we are performing chest compression, we should aim for 100 to 120 compressions per minute and allow chest to recoil fully after each compression. So we follow two-hand approach to medium-sized to large-sized dogs. Here the compressor will be standing behind the back of or the spine of the animal. Put one hand on top of the other with fingers interlaced. Place your shoulder above your hands and keep your elbows locked. If needed, find a suitable stool to stand on while performing compressions. As shown in this image, your elbows should be locked. If appropriate stool is not available, the compressor can either kneel on the table or put the patient on the floor, kneel behind the patient's spine and deliver compressions. Let's talk about patient positioning. Most dogs and cats are placed in lateral recumbency while delivering chest compressions. Only wide-chested dogs such as a French bulldog or English bulldog or pug, the chest compressions are delivered in dorsal recumbency. For a round-chested dog, for example, Rottweiler, Saint Bernard, the optimal chest compression point is over the widest portion of the chest. So here the animal is in lateral recumbency. It really doesn't matter whether it is a left lateral recumbency or right lateral recumbency. And if the dog has a keel-chested conformation, then the optimal compression point is directly over the heart. We'll be keeping the heel of the hand placed directly over the heart to deliver compressions. Example for keel-chested dogs include Doberman, Hounds. And for wide-chested dogs, like I mentioned earlier, Bulldogs, Pugs, the patients are placed in dorsal recumbency, and the optimal compression point is on mid-sternum. For cats and small dogs weighing less than 7 kilos, the ideal compression or the optimal compression point is directly over the heart. And for cats and small dogs, we don't use a two-hand technique. We use one of the following approaches: one-hand approach, circumferential approach, or one-arm approach, one of these techniques. But the number of compressions, 100 to 120 compressions per minute for 2 minutes, that remains same, irrespective of chest conformation. Coming to depth of compressions, when an animal is in lateral recumbency, chest compression depth should be 1/3 to half of the width of the chest. When an animal is in dorsal recumbency, such as wide-chested dogs, the chest compression depth should be 1/4 the depth of the chest. As you can see in this diagram, a 2-minute uninterrupted chest compressions are needed to get aortic blood pressure to a steady state, so that that provides perfusion to vital organs such as brain and heart. With shorter cycles of chest compressions, the steady state aortic blood pressure is not achieved. This leads to reduction in perfusion to vital organs such as brain and heart. So you can see in these two images, sorry. So after every 2-minute uninterrupted chest compression, there is a small break of less than 10 seconds. This is called as pause and check. This here the compressors will rotate to reduce the fatigue, and we'll check for a distant pulse in this break less than 10 seconds. So that's about chest compressions. We'll talk about intermittent positive pressure ventilation. The preferred method of ventilating a patient is endotracheal intubation. Put an ET tube, inflate the cuff, secure the tube, and connect this tube to an ambu bag or a reservoir bag. And with a peak inspirated pressure of 30 to 40 centimeters of water, deliver 10 breaths per minute. That is one breath every 6 seconds with a short inspiratory time of 1 second. Why this is a preferred method is you don't have to pause the chest compressions when the breaths are given if the animal is intubated. The other two methods of ventilation are mouth to nose ventilation or using a tight fitting face mask. The disadvantage with these methods are you need to pause the chest compressions. That is, you need to give 30 chest compressions and give a brief pause of 3 to 5 seconds. And in that brief pause, you need to deliver 2 quick breaths. But if your patient is intubated, you don't need to pause the chest compression, and ventilation can happen side by side. And when you're doing mouth to nose ventilation, you should also consider zoonotic risk of leptospirosis and rabies, etc. So these are the three different ventilation options we have during CPR. The preferred one is endotracheal intubation. So this completes the basics of the basic life support. And we'll go to the advanced life support. Remember, when a patient experiences cardiopulmonary arrest, we need to immediately start basic life support. It includes chest compressions and ventilation. It's a 2-minute uninterrupted cycle, and between cycles, we have less than 10 seconds gap. This is for pause and check, and here the compressors will rotate to reduce the fatigue. Without a doubt, basic life support is the most important component of CPR. And coming to advanced life support, these are adjunct therapies or interventions given to a patient alongside basic life support for better outcome. During advanced life support, we use monitoring tools such as ECG, capnography. We obtain IV access via IV or IO access to the patient if it is not established earlier to give drugs such as vasopressors or reversals, and additional techniques like defibrillation if indicated. Applicable reversal agent should be administered. This is very important if cardiopulmonary arrest is because of perianesthetic drug reactions. The three common reversal agents we have are naloxone, atipamezole, and flumazenil. Naloxone is a reversal agent for opioids. Atipamezole is a reversal agent for alpha-2 agonists such as dexmet and xylazine. Flumazenil is a reversal agent for benzodiazepines. These are the doses at which we should give during CPR. We'll talk about the monitoring tools. We'll talk about capnography first. Capnography is a monitoring device attached to the anesthetic circuit, which tells us about the concentration of carbon dioxide in expired gases, that is EtCO2. It also tells us about three more things. The first one is confirmation of tracheal intubation. As you can see these graphs, these waveforms will disappear if ET tube is in esophagus instead of trachea. It also tells us about the quality of chest compressions. EtCO2 value should be greater than 18 mmHg. That indicates good quality chest compression. If EtCO2 values are less than 18 mmHg, that means you should refine your compression technique. And also, capnography also tells us about return of spontaneous circulation. Whenever there is a sudden increase in EtCO2 by more than 10 mmHg and overall EtCO2 increases more than 35 mmHg, this indicates return of spontaneous circulation. Remember, capnography reading should be taken during chest compressions, not during the pause. The most important monitoring tool is ECG rhythm analysis. This should not be done during chest compressions because ECG is sensitive to motion artifact. The ECG rhythm is analyzed during the 5 to 10 seconds pause and check period between the basic life support cycles. So this is when we diagnose the primary arrest rhythms. So two of which are shockable and two of which are non-shockable. ECG rhythm analysis play a key role in deciding what therapy has to be given to the patient next. So this is an algorithm to identify arrest rhythms. We'll talk about the arrest rhythms in detail. Uh, First and foremost, the most common type of arrest rhythms you will come across is either asystole or pulseless electrical activity. So asystole appears as a flat line on ECG. Pulseless electrical activity, it was earlier called as electromechanical dissociation. It appears as a normal sinus rhythm with a narrow QRS complex. And the rate of complex formation is less than 200 per minute. Mostly it's around 50 complex per minute. Sometimes the complex can be wide and bizarre. So if you find either asystole or pulseless electrical activity, then the treatment includes vasopressors, that is one standard dose of 0.01 mg per kg epinephrine. Outside US, epinephrine is called adrenaline. That's what we call in most places. Or you can also give vasopressin. So if you're giving adrenaline or epinephrine, the dose is 0.01 mg per kg. It has to be given every other cycle of basic life support or once every 3 to 5 minutes. You can also use vasopressin at 0.8 units per kg. So what these vasopressors do is they act by increasing the coronary perfusion pressure. We should never use high dose of epinephrine, that is 0.1 mg per kg, which was given in the 2012 CPR guidelines. In 2024 CPR guidelines, they have removed the high dose epinephrine. We only have one standard dose, the low dose epinephrine, which is or adrenaline, which is 0.01 mg per kg. If you think a high vagal tone is responsible or contributing for cardiopulmonary arrest, then you should give one single shot of atropine at 0.04 mg per kg or 0.05 mg per kg IV or IO only once. And if cats and dogs undergo prolonged CPR for more than 15 minutes, then sodium bicarbonate therapy is indicated for metabolic acidosis. So as you can see in this images, high dose of epinephrine is no longer recommended. The only dose of epinephrine which has to be given is 0.01 mg per kg every alternative cycle of BLS or once every 3 to 5 minutes. If atropine is used, it is only used once early during the CPR effort. Then let's talk about shockable arrest rhythms. These are not very common. Most of the times you will be coming across non-shockable rhythms such as asystole or pulseless electrical activity, but sometimes you do come across shockable arrest rhythms. The two shockable cardiopulmonary arrest rhythms are ventricular fibrillation and pulseless ventricular tachycardia. Ventricular fibrillation is recognized by wavy chaotic line on ECG. There's a lack of consistent repeating waveforms, as you can see in the image. Whereas pulseless ventricular tachycardia, here the waveforms or complexes are more than 200 per minute. It is recognized by repeated wide QRS complexes. The treatment for shockable rhythm, a patient with shockable rhythm, that is if the patient has VFib or VTAC, then with no pulse, obviously, that is why we call them arrest rhythms. So the actual treatment for these kind of rhythms is defibrillation. So the goal of defibrillation is to terminate uncoordinated rapid contractions of the ventricle and to restore a coordinated perfusing rhythm. You can either use a manual defibrillator or an AED, automated electric defibrillator for this purpose. The dose of external defibrillator is around 2 to 4 joules per kg for a biphasic defibrillator. You can hold these hand paddles on either side of the thorax and discharge the defibrillator. And after defibrillation, you have to resume the basic life support cycle, a 2-minute continuous uninterrupted chest compressions and ventilations. Again, you'll have a less than 10 seconds pause and check. At that time, if the shockable rhythm still persists, Then you double the dose of defibrillator and shock the patient again. And you have to defibrillate every cycle of BLS. But even after two or more shocks, if the shockable rhythms persist, then we call it as refractory shockable rhythms. So along with basic life support and shocking every cycle, they also need additional therapies. So we have to give one standard dose of adrenaline or epinephrine at 0.01 mg per kg every other cycle of basic life support or every 3 to 5 minutes once. You can also use vasopressin in place of adrenaline. We have to use antiarrhythmic drugs, lignocaine at 2 mg per kg in case of dogs, or amiodarone at 5 mg per kg in case of cats. Slow IV has to be given. And a beta blocker, esmolol, is given with a loading dose of 0.5 mg per kg, followed by a CRI of 50 microgram per kg per minute. So this is a drug dosage chart we use during CPR. And this is the CPR algorithm. As you can see, we start with basic life support, then we'll start advanced life support. We use the ECG and capnograph. We'll have IV access and we'll give reversals. And then during pause and check, we do ECG rhythm analysis. If you get shockable rhythms, then this will follow the left side of the chart. If we get ventricular fibrillation or ventricular tachycardia, we defibrillate. If the if there is refractory shockable rhythms, then we'll give additional therapies such as adrenaline, antiarrhythmic drugs, and a beta blocker. And if you find if you are able to diagnose non-shockable rhythms such as asystole or pulseless electrical activity, we follow the right side of this flow chart. We give vasopressors such as epinephrine and atropine. In either cases, if the CPR is prolonged and it takes more than 15 minutes, then we need to give sodium bicarbonate therapy. And so when do we discontinue CPR? So we discontinue CPR when there is a return of spontaneous circulation. So if you feel a pulse, femoral pulse during a pause and check, and if EtCO2 value suddenly increases more than 10 mmHg, and a total EtCO2 value crosses more than 35 mmHg, that is a clear indication of return of spontaneous circulation. Along with this, the animal will also show signs of consciousness, such as voluntary movements. Animal may start chewing on the ET tube and the return of palpebral or corneal reflex. So that's when we stop the CPR. There is a concept called open chest CPR as well. So this is mostly indicated for animals with pleural or pericardial diseases, such as pneumothorax or pericardial effusion. This is also indicated for animals undergoing thoracic or abdominal surgeries, where you can directly do a cardiac massage. Open chest CPR is also preferred over closed chest CPR for giant round chested dogs such as St. Bernard. So that's all about advanced life support. And then the last component of CPR is post-resuscitation care or post-cardiac arrest care. This is the final link in the chain of survival. In veterinary medicine, almost 79% of dogs and cats with return of spontaneous circulation are either euthanized or die before hospital discharge. By optimizing post-cardiac arrest care, we can improve the outcomes. The components of post-resuscitation care are respiratory optimization, hemodynamic optimization, and neuroprotection. So post-cardiac arrest care may not be feasible in all types of clinical settings. So it's better to refer to a specialty center with advanced critical care capabilities. So I'll talk about these components of post-cardiac arrest care in brief. So the first one is the first one is respiratory optimization. So after return of spontaneous circulation, you need to assess if your patient is simultaneously breathing or not. If not, you need to ventilate your patient. After that, you need to assess the ventilation using a capnograph. You need to see if the patient is hypoventilating or hyperventilating, and you need to address it accordingly. And then you also need to assess oxygenation using blood gas analysis or pulse oximetry. Only if SpO2 reading is less than 94%, or if partial pressure of oxygen is less than 80 mmHg, then only the animal needs supplemental oxygen. So during CPR or after CPR, don't blindly give oxygen thinking it will help the patient. We'll be doing more harm because there's a concept called ischemic reperfusion injury syndrome. So only give oxygen therapy if it is indicated, if the SpO2 reading is less than 94%. So after respiratory optimization, then we go for hemodynamic optimization, the second component of post-cardiac arrest care. So here you need to check the arterial blood pressure using either Doppler or oscillometric blood pressure monitor. If the animal is hypotensive, that means if mean arterial pressure is less than 80 mmHg and systemic arterial pressure is less than 100 mmHg, then you need to figure out the reason for hypotension. If the hypotension is because of hypovolemia, then you need to give IV fluid bolus of 10 to 20 ml per kg over a period of 15 to 20 minutes. Or if the hypotension is because of vasodilation, then you need to give vasopressors such as norepinephrine at 0.1 to 2 microgram per kg per minute, CRI IV. And if the hypotension is because of decreased heart contractility, then you need to give a positive inotrope such as dobutamine at 10 microgram per kg per minute IV. And if the animal is hypertensive, you need to discontinue giving vasopressors. And you also need to investigate why the animal is hypertensive. Is it because of pain or anxiety? And you need to treat it accordingly. The third component of post cardiac arrest care is neuroprotection. If the animal shows signs of increased intracranial pressure, such as if the animal is comatose, or if the animal has a very decreased mentation, or if the animal has a persistent apnea or hypoventilation, that indicates the animal is having increased intracranial pressure. You can give either mannitol or hypertonic saline to reduce the intracranial pressure. And if the animal experiences acute seizures during post cardiac arrest period, then you can either give benzodiazepines or levetiracetam is used to treat seizures. So this is in brief about post cardiac arrest care. So it includes respiratory optimization, hemodynamic optimization, and neuroprotection. Coming to prevention and preparedness, a thorough pre-anesthetic evaluation or pre-anesthetic check of the patients and close monitoring of patients under anesthesia, it's very important to decrease the incidences of cardiopulmonary arrest. Your clinic should have an emergency crash kit, uh, and your team should be familiar with the crash kit. So this emergency crash kit should contains vasopressors, reversal agents, and then positive inotropes such as dobutamine, dopamine, and all the emergency drugs mentioned in the emergency drug dosage chart. And make sure you have pasted these drug dosage charts on your clinic or OT walls. And a refresher training or mock drills should be done frequently to have everybody on the same page. Let's talk about communication and team dynamics. During cardiopulmonary arrest, usually the most senior or experienced person in the team will take up the leadership. The leader will assign roles to the team members, such as who is the compressor, who is the ventilator, drug handler, and recorder. There should be closed loop communication. The messages should be very brief, clear, and timely. Situation awareness and cross monitoring is also extremely important. This is all followed by debriefing session. Coming to take home messages, download and read the RECOVER CPR guidelines, and then take printouts and paste CPR drug dosage charts and algorithms in the clinic and operation theater. Please take consent and obtain resuscitation code from pet parents before admitting the patients. You can also download RECOVER CPR app via Google Play Stores or Apple Stores. The 2024 RECOVER guidelines, it's an open access article. Anybody can download it. If somebody is really interested to know more about CPR, you can also go to American College of Veterinary Emergency and Critical Care website. they offer courses on CPR. There's a course on basic life support. There's a course on advanced life support. There's a course on post cardiac arrest care. I highly recommend these courses for people who see a lot of emergency cases on a day-to-day practice. And yeah, I'm open for questions.
Thank you so much, Dr. Sumant. That was amazing. Super, super informative, very interesting. But yeah, thank you. That was great. If anyone has any questions, please do comment them and we'll go through them now. So yeah, ask away. And otherwise, I think Dr. Sumant has very kindly provided his email on the slide there for you to email him if you think of anything afterwards. This is recorded as well, and it will be going up onto our WVS Academy webinar channel on our YouTube. So if you'd like to go and have a look, the cat anesthetic one that we did before is up there now. So you can scan that QR code and find us on YouTube. And give us a follow and give us a like and come to more of our webinars. But yeah, if anyone wants to ask any questions, there's no such thing as a silly question. It's a safe space, so please do type in the chat and we'll do our best to answer them. But I have a question to start with, if that's okay, because I was just thinking, obviously, in most situations, people would just be doing manual ventilation with IPPV, but is there any cases where if you had access to an actual ventilator as part of your anesthetic machine where that would be appropriate, or should it just be manual?
Yeah, during post-cardiac arrest care, and if the animal is not spontaneously breathing, so we'll start doing manual, intermittent positive pressure ventilation. But again, if the animal takes a long time to breathe, so it's always better to connect to a ventilator because the person doing it will get exhausted after a period of time. It's always helpful to have a ventilator in place.
Mm-hmm. So it's kind of if you have it, you can utilize it, but if you don't have it, then the basics is absolutely adequate.
Yeah.
Okay, we have our first question. It says, do you have any experience using the esophageal intubation during emergencies?
We do endotracheal intubation with emergencies, but sometimes in a hurry, somebody can wrongly put the AT tube in the esophagus. But if you have capnograph at your practice, it will help you to recognize whether the endotracheal tube is in the trachea or in the esophagus. So you can troubleshoot with the help of a capnograph.
Yeah, and having a light to be able to look down, that's also, I find, very helpful to actually be able to visualize that it is in the trachea. So we've got another question, and that says, a cat is coming with severe dyspnea. Should we do an RSI and put on a ventilator or manage otherwise? I think I'm not entirely sure what RSI stands for, but you might know.
Yeah, if any cat has come with a severe dyspnea, the first thing you need to do is check the pulse oximeter. Use your pulse oximeter to know the oxygen saturation level. And in most of the cases, they will be needing supplemental oxygen. Not necessarily ventilate them, give supplemental oxygen and try to do a T-fast or a quick lateral radiograph to rule out if it is a pneumothorax or pleural effusion. If it is a pleural effusion or pneumothorax, we generally do an emergency thoracocentesis. So in either case, we have to really give oxygen supplementation first.
Yeah, apparently it's RSI stands for rapid sequence intubation. So I don't know if you want to speak about that, or so whether or not, it would be that or on venti.
We can, I think, if it is, it's better to intubate them and then connect to oxygen support if at all possible.
We have another question. So this is from somebody who says that they're not a veterinary professional, but they are a fosterer. So they don't have immediate access to vet care, and she just wanted some access to some practical resources, I guess at a more non-vet level, that's helpful.
Yeah, with respect to CPR, basic life support is something anybody can do. Need not be a vet. But like if anybody is interested to know about basic life support, the chest compressions and ventilation, they can download the RECOVER guidelines. But advanced life support is something a vet does. I think Dr. Paula has a question that, I mean, she meant supraepiglottic device. Do we use them during CPR? Like we have something called as VGen, which is a supraepiglottic airway device. We generally use it in place of ET tube for regular gas anesthesia monitoring. But in the guidelines, they have not mentioned using a supraepiglottic airway device for ventilation. They would rather recommend use of endotracheal tubes, ET tubes.
Yeah, I think as far as my experience with them is it's they're used quite a bit in rabbits.
Cats.
But they don't provide that great airway security, do they?
Yeah, it's an alternative to ET tube in rabbits and cats. They're great for routine, gas anesthesia purposes. But for CPR, I think ET tube is the way to go.
So yeah, we've got a comment from somebody who's just expressing how difficult it is when there's a lack of access to veterinary care and proper support, and of course we understand that, and it's very sad that that is the case in some areas. But as Dr. Sumant was saying, trying to learn about basic life support and what you can do at the most basic level will still help, and it's still the primary thing to start doing first of all until you can seek any further care.
Yeah, in Indian context, I mean, any veterinary student or anybody related to animal welfare field can definitely learn the basic life support. As I mentioned, it is the most important component of CPR. The advanced life support, they're all just adjunct therapies. If you do a really good job with chest compressions and ventilations, there's a high chance you may revive a lot of patients. So I think knowing the right technique, how to compress, the optimal compression point, the right way of ventilation, I think these two things at least anybody can do, if there is no access of other drugs at least.
Yeah, and the more that we raise awareness, the more that we educate, the more that we discuss this topic, hopefully, obviously in time, then we gain further resources, and when we are able to have them, we actually know what to do with them, and then we can provide even better care than we already were doing. So it's great that you're on this webinar, and that everyone else is as well, to learn more about this, because this is where it all starts.
Thank you, Dr. Bhatt. If anybody has any further questions, my mail ID is on display. You can kindly mail me. I'll get back to you.
Yeah, if you've got maybe a few more seconds if anyone's got a last minute question, but otherwise we'll probably wrap it up there. And yeah, like Dr. Sumant said, he's very happy to be contacted. And also you're very welcome to check out the WVS Academy website, our YouTube channel. We have lots of information on our social media as well. So it's great to have you all with us. And thank you so much, Dr. Sumant. That was fantastic. And we hope to see you all again soon. So everyone take care and bye.
Thank you so much.